Hello and welcome to the knee pain education session delivered to you from Southport and Ormskirk Hospital and our joint health department here. First off, why am I here? So research has shown that early advice and input can prevent longer term pain, and understand a little bit more about your possible condition, a little bit about the anatomy and how our healing processes work can significantly decrease the chances of progressive longer term pain. Most people with pain want to know four things: what's wrong with me? How long will it take to get better? Is there anything I can do to help myself now? And then is there anything that the medical professions can do to help? And hopefully we'll help answer those questions for you as we go through today. So today, as I said, we'll discuss some knee anatomy, some of the most common causes of knee pain, treatment in terms of what you can do before you see us in department here, what can you expect from your appointment, benefits of exercise and activity pre-appointment, and also managing setbacks and those bad days and challenging some of those. So in terms of knee anatomy, you can see a couple of pictures on here. They don't go into too much detail, so they should be relatively digestible for yourselves. But we'll just touch on some of the basic anatomy and structures within there that aren't so self-explanatory. So the knee joint itself is a hinge joint, which means that it only is meant to move in one plane of direction through flexion and extension. The main thing that keeps that nice and stable when the knee is static is your ligaments. So the ligaments' job is to attach and stabilize bone to bone. So as you can see on the image on the right, that white banded structure on the far hand right of your screen is your medial collateral ligament, and that job is to keep the femur and the tibia from translating over one another. Of course, the ligament's job alongside attaching bone to bone is to transfer weight and forces along to make sure that the knee joint's always in the correct place. But sometimes we need that to happen when the knee is moving, or dynamic knee structure support, and the moving or dynamic support is normally from the muscles, and their job is to move the joint, work alongside ligaments, but also similarly work like ligaments in transferring weight through the joint, holding good positions through certain movements and turning muscles on and off to maintain those desired positions. And sometimes these static and dynamic stabilizers can be slightly mixed. So some people could unfortunately experience a complete tear of their ACL or their anterior cruciate ligament, which you can see in the image on the right hand side, and that normally stops anterior translation of the tibia. So it stops the tibia bone shifting forwards underneath the thigh bone. But we can use dynamic structures like muscles to compensate instead of surgical repair, and we have some really nice outcomes for people with ACL tears, rehabbing them conservatively with muscle strengthening and getting some really good function back, therefore avoiding surgery. So the dynamic and static stabilizers do definitely have some crossover. In terms of cartilage, that's the majority of the tissue you can see in the middle of the knee joint, and that tissue overlies the joint surface. There's different types of cartilage, like hyaline cartilage, for example, which is a very hard surface, and that's the surface you can see on the underside of the femur. But this allows us to move joints without damaging the bone, so it allows the transfer of weight successfully, but also acts as a little bit of a shock absorber. The meniscus is on top of the tibia, about a 1 centimetre structure that covers the surface of the tibia in the superior aspect in the joint line there. The main job of the meniscus in the knee is that it doesn't cover the whole joint surface. Essentially, it's tyres with two holes in, if you were looking from a bird's eye view, and the two heads of the femur where the hyaline cartilage are closest to the knee joint line there sit inside there. This allows for some really nice cushioning and some controlled movement between the two, and sometimes when we see osteoarthritic knees, that cartilage has been worn down over time. And finally, the knee joint is then filled with synovial fluid that runs in between the surfaces of the joints and nourishes the cartilage, the joint surfaces, and the joint itself, helps to reduce friction and allows that joint to stay nice and lubricated throughout day-to-day life. So what is wrong with me? And the majority of those people that have knee pain that should be watching this video from our department will likely have one of the following. So either a sprain or a strain, which is most likely through injury, where you've either moved or fallen in the wrong way, fallen in a strange position, pulled or strained a muscle, and this can be quite common due to the amount of attachment sites that are in and around the knee from a muscular, a tendon and a ligament perspective. Anterior knee pain or patellofemoral pain. This is a little bit similar to non-specific lower back pain, where it's mostly a diagnosis of exclusion. The knee itself is very structurally sound. There's no specific tissues injured or causing problems that we can identify, but you often see a bit of global deconditioning, global weakness in and around that knee, or specific weakness or deconditioning in and around that knee, which then alters the biomechanics or alters how that knee moves. This can then start to apply pressure on areas where it's not meant to, and the pain systems, the peripheral nervous system, can start to pick up on this and start to relay pain as a complaint. Meniscus or cartilage damage. This can be done through injury or can be age-related. Similarly, OA is normally age-related changes to the cartilage bone and the joint capsule. And if you want any more information on osteoarthritis, then have a quick look at our OA videos, which are on the channel. Tendinosis or tendinopathy, where this is where the thinner part of the muscle attaches the muscle to the bone. Thinner part of the tendon, that attaches the muscle to the bone, and this structure can change over time. It can be stretched too much, it can be repetitively loaded a little bit too much and become irritable and causes some problems. And then finally, bursitis, which often occurs with tendinosis, and these diagnoses can also be mixed, but those are the main things that will occur in and around the knee joint itself. How long will it take to get better? The golden question. Well, this is important because knee pain can be acute, subacute or chronic, and that's only a time frame, as you can see, 6 to 12 or over 12 weeks. And we know that if you follow the advice below, then you're likely to reduce your pain quicker. Trialing relative rest and avoiding those really aggravating activities is really important. Exercising outside of pain and making sure that you have the ability to do so. Wearing correct and supportive footwear, maintaining a healthy weight, taking your time with tasks, especially if you're in a painful situation, thinking about the task that you have in hand, and is it really appropriate to be doing it if I'm already in this much discomfort, and then taking adequate, consistent medication to help control your painful symptoms. The table on the right there is, as you can see, tissue repair phases and timescales as a general average. So post-injury or post-tear, and this depends on the severity of the injury, but you immediately get bleeding and inflammation within the area where that injury has occurred. And the inflammation can last for a few weeks. The proliferation phase then begins and lays over quite heavily with the inflammatory phase, and that can last for weeks up towards months. And then the remodeling, the relaying, and the true healing phase occurs between weeks and a few months. But the healing time, and the reason I'm being vague there, is because the healing time varies greatly from person to person. This can be to do with your past medical history, if you have any circulatory issues, it can be due if you've had any previous injuries in that area, etc. So it is a little bit of a mixed bag, but generally with injuries, the first 6 weeks is a chemical build-up of repair and inflammation. At 6 weeks, the majority of the inflammation should have occurred, and then scar tissue begins to lay down. 6 to 12 weeks, the pain system returns to normal after that remodeling is done. But sometimes that pain system doesn't adapt very well, and then the pain continues, and sometimes pathologies can then change in how they relate to us. But these are all things that your physiotherapist will be monitoring and looking at very closely, and then changing and applying physical activity and home exercise programs to combat that. If your injury has been quite recent, then it's important that we look after that injury from an early stage, and what we tend to advise is the use of PRICE. So PRICE is just a way of remembering how to respond to the injury, and it's an anagram which is responding to protection, rest, ice, compression and elevation. And the leaflet that should have been sent out to you can have more details in there for you. Some parts of PRICE are also relevant for managing pain beyond the initial stages of injury. So remember that rest and relative rest is a really important aspect. Knowing when to rest and when to stop pushing yourself. is really important, and again you can discuss that with your physio. But they're the 5 things that you should follow at an acute injury, specifically if it was acute and if it was a fall or something along those lines like we discussed at the start. In terms of managing that pain, we need to try and think about the rest versus activity argument and the use of relative rest, reducing or avoiding the activities that are causing significant additional pain or discomfort, causing swelling or causing changes to the joint that you can see. But it's really important that we move, and movement exercise is really vital in increasing blood flow and preventing stiffness in the longer term, which again is important in the healing process. So it's a bit of a catch-22, and we're trying to find the right balance before you come in to see us. Obviously, before you see us in department here, erring on the side of caution is always wise, but don't avoid moving your knee completely, and try to do some form of paced activity whilst those pain levels are staying manageable. That might just be extending and bending the knee. Whatever activity is most comfortable, I'd encourage you to complete it as much as you can with inside levels of comfort. The use of ice or heat is also another area for debate, specifically after an acute injury. But we know that the use of ice is useful in managing pain and can be useful in managing swelling in the acute phase of an injury. So we encourage you to use it through the day to help manage those pain levels, and use it to help continue movement and exercise. If you're icing it, I'd encourage you to use compression as well. Ice for about 15 to 20 minutes, never directly onto the skin, and up to 5 times a day, using the technique in the middle there, wrapping the crushed ice. But heat is also a good alternative after that very acute phase, so 2, 3, maybe 4 days after the injury. I'd then apply heat to it, continue to promote movement and activity, and then you can also look at using your anti-inflammatory gels and your other oral analgesics and pain relief, which we'll come on to now. So painkillers, should I take them? The answer in simple terms is yes. They can help keep you moving, and they're really important in preventing those chronic pain pictures and preventing early immobilization of the joint, which has complex issues as we move forwards. If you're already taking medication for something else or you have any other problems, then always have a quick chat with your pharmacist first about what medications would be best for you. But we very often hear patients say, will my painkillers just mask the problem? Well, I'd think of them as pain control rather than painkillers. They're never going to fully eradicate the pain, and they don't always address the underlying causes for that pain, but they do reduce the pain response. And this doesn't mean that the pain system stopped working, it just means that we're dampening the effects of it, and we can still then apply some more normal movement patterns and allow ourselves to do a little bit more activity in the stages where the pain relief is being most effective. There'll still be a painful response created, but it won't be as severe. So we do encourage you to take those painkillers. Make sure they're regular, and make sure that you have taken advice from your pharmacist as well. So the disuse cycle, or the vicious cycle that you can see in front of you, is something that we use quite regularly with our patients, mainly to help compartmentalise different stages of an injury. And the first thing top right that a patient will notice is pain. If it was an injury or a pull, or we've just woken up with pain in our knee. That's the main symptom that we tend to understand as humans, but it's important to understand some of the current evidence around pain, and that in the past the old theory of pain was that the level or severity of pain directly relates to the level or severity of tissue damage, but we know that that's not true. Pain is very complex, and it's not always as simple as that, and the level of pain is not always associated with actual tissue damage. So we can have more pain than the damage that's actually occurred within our body, and in this case within our knee. So if you have a look at that cycle, and what we'd normally do is of course guard that issue and relax it. And then we have these 3 or 4 things that occur after a period of guarding or a period of rest. We get muscle spasm, restricted mobility, weakening muscles or wasting muscles, and then loss of normal function. This leads to the patient to anger and frustration, and all you really are contextualizing there is the pain and then the frustration. We're not looking at all these other issues, and these other issues are why it's so important to keep gentle movement continued even when we feel like we've had a nasty injury. So is there anything medical professionals can do to help? Well, yeah, physiotherapy, of course, is a two-way process, and the patient actually plays a majority role in leading their own recovery by completing what we ask or what we prescribe of them. But the assessment itself will include a subjective and an objective assessment. The subjective essentially is just the conversation that we have on assessment when you come to see us. We're asking a specific set of questions around the pain, the type of the pain, aggravating and easing factors of it, when it came on, how long it's been there for, along with lots of other types of special questions which help lead us down a diagnostic pathway. And after the subjective, we've probably got 5 or 6 ideas of what it could be. And then we move on to the physical examination or the objective examination. And this is when we're looking at that knee joint itself, how well it's moving, is it tight, what muscles or structures seem to be impacting, and then we normally run some special tests to see if there's any particular structures that are causing problems. We then should explain that consultation back to you and create a bit of a plan for you going forwards, and that plan normally involves treatment. And that treatment will vary from person to person and from patient to patient, but it normally consists of a core set of values of advice, education and exercise strategies, all really important parts. Then specific and tailored home exercise regimes and programs. The use of stress and relaxation techniques is also really important. Head to the Smiling Minds app and have a read through that if you're interested. And then occasionally we do some hands-on treatment as well. Make sure you always come into our department with comfortable clothing on, if possible. Like most things, there are other treatment options, and the reason these treatment options are in place largely is to make sure that we don't miss anything, but we will always start with some form of conservative management if we feel like the condition doesn't require any immediate intervention. So podiatry cannot be an option, and in some cases foot posture and foot biomechanics can affect the knee and affect the knee pain. Changing in pressure gradients and pressure areas and putting excess pressure on certain structures depending on the biomechanics of that foot. And if we feel like that's the problem, a referral will be sent on and we'll support you up until the point where your podiatrist is happy. Steroidal injections and surgery are both things that we don't do lightly in the department, and we will only do if we feel like it's necessary to do so because of the associated risks with invasive therapies like those two. But the steroidal injection doesn't change the underlying problems and often doesn't address the underlying problems of the pain, but it can give you pain relief and make changes to improve the longer term management. So often it can help us with exercise interventions, giving us a period of pain-free movement. Surgical intervention should only really be considered after conservative management has been tried, and we would probably want you to see more than one physio in our department before we send you on for the opinion of a surgeon. This is really to make sure that the decision is correct, but often the high pain levels with poor movement stability or poor condition of the knee can be fixed or treated through physiotherapy rather than surgery, and that will always be our first option. So outside of the advice that you've already been given, we know that exercising nice and regularly is important, and exercising outside of levels of pain is important, so that might mean adapting what you consider normal for you. But coping with bad days is also a really important part too, and we don't want to get too hung up on these bad days, and of course we want to have as few as possible. But remember, when you do have those bad days, what helps reduce your pain? Is it relaxation, distraction? Is it a certain pain relief? Is it heat? Is it a certain movement? And no matter what that is, make sure you find it and use it again. Always remember to take regular analgesic pain relief, and if you need more pain relief or you're querying around the strengths of certain ones, then speak to your pharmacist and ask them for some help. Remember to maintain gentle movement. Self-massage is absolutely fine, and then a gradual return to normal activities, but changing them and pacing them slightly so you're not doing too much at any one time. This is really important to avoid the boom and bust cycle. So as you can see here, start off on a really good day with loads of activity up the left hand side, and then the next day we do hardly anything because we're really paying for it the day before, and then the good day doesn't feel quite as good, the bad day is still the same. And if we continue on that trend, we'll gently do less and less and less and actually end up in a place worse than where we started. So instead, we should start small with that good day, only half the amount of activity, and gently see that trend increase as we adapt to that activity more, strengthen, and they're able to do a little bit more day upon day, rather than starting really fast out the blocks and causing yourself more harm than good. But the reason why this boom and bust cycle is important is you need to be consistent. Consistently doing the same activity will only get you so far. We need to consistently do the activity and then progress it. The do's and don'ts on successfully managing your knee pain. Do maintain a positive outlook. Make sure this knee problem doesn't take control. Find ways to get around it, maintain active levels of exercise, and maintain a positive outlook alongside that. Take your medication regularly and ask for advice if you feel like you need it. Balance rest and activity as best you can, and remember that even when we're feeling stiff and a little bit painful, there's still things we can do to help with that knee joint, even if it's just gentle bending and stretching, even when we're sitting down. Pace activities, compartmentalise them and spread them out across the day. Try the exercises you've already been given and get in touch if they're not suitable for you. Stay nice and active and relieve stress. Use those techniques to get rid of anything else going on. Don't bed rest and let the problem get hold of you. Don't be part of that disuse cycle where we see lots of deconditioning. Avoid the activities where you kneel or squat and do really deep flexion activities of the knee. Avoid bracing and tensing the body and getting yourself in a position where you're already in pain before we've tried to start moving. Wear some sensible footwear and don't worry. Most knee pain improves with advice and exercise inside 6 weeks, and we will constantly be assessing and reviewing to see how your progress is going, and if we feel like we need to change anything, look for further management or look for further investigation, then we always will do that accordingly. So in terms of what's next, follow all the advice you've been given today. Have a quick look through some of the other videos that are on the channel. If you've not already started, try the exercises now. Start small and build yourself up gently over time. There's loads of additional resources online around knee pain. Physiopedia is a good place to start if you're looking more interested in around anatomy and physiology, and the leaflets and exercise programs that are sent out to you should be your first port of call for information. Thank you very much.